Hi everyone, this is Lahir and I'm from ABCs of Anaesthesia. So I'm a consultant anaesthetist in Melbourne, in Australia. And today I've got Alan with me. So Alan, welcome to ABCs of Anaesthesia. Now you reached out to me just because you wanted some interview practice and advice. And I thought, another great opportunity around this time of interviews to just give you some questions, throw some random stuff at you, and we'll just pause and give you some feedback on that. And hopefully, like, you've got your interview next week for a pretty important job. So hopefully this is useful for you. So Alan, just to start with, tell us a really little bit about yourself, where you're at, and let's get started.
Yeah, sure. So first of all, thanks for having me. I wasn't expecting a response from, your platform. Lots of people follow you. So a little bit about me. I'm Canadian originally. I'm currently PGY3. I work at the Royal Brisbane as an ICU PHO at the moment. That's me.
You got your interview happening. Hey, so just to give everyone a bit of background, so I'm one of the critical care supervisors. So it means that this, like, literally just in the last couple of weeks, we had to shortlist from about over 200 applicants down to we had 13, maybe 11 for the interview for the actual interview for critical care jobs, and it's a harrowing procedure. Just trying to go through everyone's CVs and give everyone a really fair go. And then I've got to say, so specifically for the interview, I feel like everyone had something exceptional about them. And when I was asking them questions, it felt like everyone sounded pretty similar, which is kind of annoying to me because I knew looking at their CVs that people were exceptional. But one of the big things was that, and potentially we'll talk about this in a second, is that when people answer questions, it seems like they say a lot of words and buzzwords. A number of times people talked about reflecting and talked about, their brand and stuff. And these are all fine to use buzzwords, but to not have substance that they've actually got behind them, like they've got plenty of stuff on their CV, why not mention some highlights? And I think that was a big part of the take home from me, that everyone sounds the same, but they're exceptional, unique people that have been shortlisted from over 200 people, and they could, do a lot to highlight that. So that said, Alan, let's just get started. Because the best way is to get in there, make some mistakes, do some, say some good stuff, say some stuff you want to change. Doesn't matter. We're here to improve. First kind of warm-up question, Alan, tell me about yourself.
Yeah, sure. So a little bit by myself. As I mentioned, I'm PGY3 at the Royal Brisbane at the moment. Originally from Canada, born and raised over there. Did my undergrad in the United States, actually, in North Carolina, and then followed my dream to go to medical school. So I did that at the University of Queensland. So that's me. I guess a little fun fact about me, before pursuing medicine, I was a professional tennis coach. So I went to Wimbledon and the Australian Open. So that's something I'm proud of. But yeah, that's me.
Good. And so in that question, I love that you gave it a little bit of intro. Born in Canada, med school, followed my dream in med school, and now got into medical school in University of Queensland. And in that question, I specifically do want you to tell me about your academic stuff, your clinical stuff, and give me the highlights. And I'd love the fun fact. The fact that you went to Wimbledon, so that's a ridiculous point of difference. And the talking point, it's absolutely separate too. Definitely mention that, and at the end, as the absolute, the dessert that the interviews go, wow, that was ridiculous. So go straight for your clinical and academic now. So tell me about kind of your clinical and academic highlights.
Yeah. Okay. So clinically, I've tried to put myself in positions where I could become a well-rounded doctor. So I've had clinical experience as a rural ED PHO, and also experience as an ICU PHO at a quaternity hospital. So that's one main clinical thing that I'm proud of. In terms of academics, I'm heavily involved in research. I've been involved in a large RCT and ongoing with audits as well within different departments. I'm also an academic title holder at the University of Queensland, which speaks to me being involved with, the UQ OSCEs, an MMI interviewer, being a mentor for other international students coming to UQ. In terms of managerial things, I've been involved in committees, a lot of committees at through the University of Queensland. I'm also on the medication committee at the Royal Brisbane, and also the founder of UQ Business, which is a little business group that I started in medical school. And from a personal side of things, I guess I kind of talked about that a little bit earlier. I have this kind of unique path. Before medicine, I was a professional tennis coach, which instilled in me a few characteristics like hard work and diligence, which was translated to medicine. I was fortunate enough to be rewarded the medical doctor of the year at the Royal Brisbane as an intern. So, those are kind of my
That's good, Alan. So first of all, when you say your clinical, first of all, that's great. You got lots of stuff that you can brag about and highlight. And by the way, it's not bragging if people ask you the question, right? So that makes it okay for us who don't want to big up ourselves.
It's still awkward though. I feel like we all hate doing that.
And it's a practice skill. Like it sounds so awkward, right? So first of all, when you say your clinical stuff, that's the same. Everyone's done it, right? So how is that possibly a point of difference? I want you now to tell me, so in your clinical stuff, tell me the highlights. Like, so I really love the critical care space. I've been an ICU officer for this, and I've been I've done my anesthetics rotation. I love emergency, and I love the fast pace of that. But and then straight go to, and during this time, I recall some really intense moments of managing arrests and successfully as well as unsuccessfully. And I've learned a lot from these instances. Like to say, and if there is one really big incident you could relate to anesthesia in some way or not, I feel like that suddenly puts in a point of difference of you. So is there something in your clinical work that you just go, well, that was a highlight?
Yeah, for sure. I guess the main thing that kind of speaks to me is that when I was a house officer on neurosurgery, on the neurosurgical service, I've done 20 weeks of neurosurgery at the Royal Brisbane, and there was an airway emergency. So I was one of the first doctors there on scene. I initiated, typical management. But the main thing that kind of comes out from that is when obviously the emerge buzzer was hit, and the anesthetic advanced trainee came to that bed space. It was a chaotic, bed space. There was a panic in everyone's faces, and when the anesthetist was there, he took command of the case, allocated different roles, all while managing this deteriorating patient. So that was something that I saw, and I was like, wow, I want to do that. So that's one big case that I remember. And I was fortunate enough to have those 20 weeks on neurosurgery to experience that.
Yeah, okay. And good. So, you're given something to highlight the reason why you want to do anesthetics, and potentially if you were to also, mention that, I did everything I could in a stepwise fashion for management of this airway emergency and hypoxemic patient. And then and I was really proud of just the way I fall back to basics, doctor's ABCD kind of mentality for optimization of the airway. And then to see the anesthetic trainee come in and, just solve this problem, like, do advanced airway maneuvers. I realized that at that point, this is definitely something I want to learn. I want to have the skill set. So, it relates to your skills as well as the fact that you were inspired to do anesthetics at that point. And most importantly, at the end of the day, I think people recall very little about most of what you're going to say, but if you give a good emotion to them, that you present intelligently, you speak well, you're humble enough, you don't go too overboard, and you've got relatable stories. I think that's the biggest thing. So all of that's really good. How about the stuff about in the academic space? Again, I want you to say, so academically, I really enjoy teaching. I'm heavily involved in research, and then give me the highlights for each of those. Because I think, and you did mention it, the fact that you're part of an RCT. Have you published yet?
No, so no publications. That's amazing.
That's right.
Yeah,
that's right. So you can easily just kind of skip over that. You're involved in lots of things, and I think the highlight for me here is you were the reviewer for an undergrad neuroscience journal. That, like, not many people have done that. To highlight that as part of your research suddenly makes the other stuff less of a concern. Like, oh, you haven't published, whatever. I've done that.
Yeah. Okay. That's good. That's a good point.
Do you want to have a go at getting straight into your academic stuff? Yeah.
Yeah, sure. So, academically, I've been involved in research. I guess I've been part of a randomized control trial, really from protocol development to ethics approval, all the way to data collection. And at this point, the manuscript is being typed up. And also, as an undergrad, I was an undergrad reviewer for one of the first online undergrad journals in the United States. So that's something I'm very proud of.
That's good. And now, probably good to talk about that other point that came up, which is how do you know how much to talk about? And that's a really good question because, first of all, you should know the timing of the interview and roughly how many questions, and then you divide it. So, 20, so say you got 20 minutes, 4 minutes a question. If there's 5 questions, every time you practice, you kind of want to have most of your good stuff out in that first minute. So strategically, if I was to say an answer like, yep, so tell me about yourself type question. You go straight into the fact of where you're from and your journey very briefly. You hit the high points of your clinical, your academic, and the fact that you're a founder of something. That's the stuff you should name first, by the way. And then you just give a teaser of it. So hopefully you can get all of this out in 1 to 2 minutes. And then if they look like they want more detail, they probably won't for that first initial question. You can then go in and go, look, in more detail, this is what I did for this randomized control trial. This is what it was like working as a reviewer. This is what it was like being the founder of something. If you're ever the founder of something, that's just a really big thing that, you can talk about, I think.
Okay.
Hey, let's go on to the next kind of question, which is situational. So when is the time that you were criticized in the clinical environment?
Yeah, sure. So one event that I can remember was when I was an intern. I was on my mental health rotation, and I was having my mid-year review or my midterm review with the consultant psychiatrist. So it was all good criticism. It was all good feedback. The main points that came out from there was, I'm not prioritizing my investigations early enough, my consults early enough, and my notes could have a little bit what I did, I asked the junior house officers or the registrars, what should I do to try and get a little bit better here? Got some info from them, asked the consultant directly what he suggested. And, they gave me a few tips that I implemented, and what I did, I came in a little bit earlier to pre-type my notes. I prioritized consults early in the morning and prioritized investigations early in the morning, and all the rest of the jobs throughout the day, then I would attack those systematically. I guess what happened there was that was well received. All my jobs started to get completed. And then throughout the year, I used that. And I was lucky enough, once again, to be nominated as intern of the year at the Royal Brisbane, which was a great honor for me, it kind of speaks to my hard work, and I'm proud of that.
So even when you're speaking, I can tell that you definitely don't want to brag. You feel almost embarrassed by saying that you were awarded something, and that's a problem. Like I think, first you got to practice it. You got to practice knowing that if they're asking you the question, it's not bragging. I like the fact that you say I'm really proud of that, because it does soften the bragginess of it, which is a very good strategy. And I think that works really well for you. So keep doing that. But to not have that look of slight embarrassment, or maybe even shame is the right word. Like you just don't need to feel bad for that. I want you to practice saying this stuff in front of a mirror, in front of your partner or your loved ones and your family and friends, because if they don't pay you out for something, then you can make it work. So that sounded really. What's your approach for that? Do you have the approach for situational things?
Oh yeah. So like you guys have been teaching for a while now. So STARR. So situation. What was the task? What action did you implement? And what was the reflection or the result? Is kind of how I tweak it from that situation.
Yeah, good. STARR approach. You give a clear result that you got your work done and you were finishing things appropriately, and then the reflection. The reflection is almost the fact that you got this, award. It's like, wow, that really worked, and it was just so satisfying that by first of all, getting feedback, asking people how they did something, tweaking your system. That's a really. that's a really good situation. That's a really good example. It started out like, oh man, it was kind of soft level stuff, which is totally fine in the intern resident level. But the fact that you got such a big outcome out of it makes this situation a lot better. I was about to ask you, go, yeah, that's great. Did anything really wrong happen? Like a serious mistake happen? Because that was almost too soft of a thing.
Yeah.
But so let's just go with that. Did any, you don't obviously give no specifics or anything like that, but did you have any kind of more serious issues that came up during your intern residency that you had to work through?
Yeah, no, definitely. One that comes to mind was once again when I was on the neurosurgical unit. What happened was there was an agency nurse that was looking after this patient post-operatively. So a nurse that wasn't, used to neurosurgical cases. My job was to clerk the patient post-operatively, write the notes, write the plan, and write up all the regular meds. And what happened there was the plan was for the patient to receive VTE prophylaxis the next day. So I wrote that in my plan. I didn't cross it out in the medical chart as it was a new chart. So that is a mistake that I did. And the VTE was given to the patient post-operatively, so post-craniectomy. So pretty big issue there. So what I did, immediately I escalated this to the registrar, the neurosurgical registrar, who told me, okay, let's increase the neuro-obs and we'll follow this patient up until tomorrow to see if there's any issues at all. Luckily, nothing came about it. There was no bleeding. There was no complications, which was great. But outcomes from that, a risk man was placed, and which was completely fair. And what I learned from that is, communication is not only written or, verbal. I also need to go and, make sure that I'm following up with, these types of clinical scenarios, keeping in mind that, might be different staff that are at the bedside. So communication is key.
Yeah. Okay. Good. Yeah, that's good. And I definitely, if you're going to pick a scenario, the first one is great because it's got such a win at the end of it.
Okay.
and that scenario, yeah, it's good. The result was that, fortunately nothing happened to the patient. They were absolutely fine with the increased neuro-obs. No adverse events occurred, and the action you took from then on was to be just more thorough. It's the thing of being more thorough. Like it's hard to even fix that because you're probably just incredibly busy on a neurosurge rotation, and you probably had like so many other emergencies happening or other things. It's hard to know how to exactly tackle this thing of just it was just a lapse, right, of being in a busy ward.
Yeah, I just didn't cross out the box because it's still handwritten at the Royal. So you write all your notes and everything. Oh well, you write your notes handwritten, and then you're supposed to go and cross it out and write everything. So
the take home for me in that is that I realized I think after debriefing lots of colleagues, because I was obviously very disturbed that I missed that. All my colleagues have reported that little things do get missed, and that's just natural being in a very busy environment with adequate hours and inadequate staffing at times. And what I learned from that is, first of all, the incredible need to be thorough and experienced and have very, stringent, systems for, writing your plan and then checking your med chart and your OBS, and the variables are all in place and completing that before you go on to the next patient. But also the fact that I realized that the mistakes do happen, and there's a system to try to make it better. That you can, debrief with your colleagues, figure it out. I almost feel, do a risk man, look at it in your M&Ms to get a whole team approach to something. And I'm almost like that reflection. It might be a bit better because it's hard to just fix a lapse in judgment, but it is a better thing to fix than a whole system. So if you are going to use that scenario, I reckon I'd go with that.
Yeah, no, that makes sense. That's great.
Hey, how about when was a time that you sacrificed your own progress for the benefit of someone else?
It's a very good question.
It could be clinical or non-clinical, like just in your social life or...
Yeah. I think so. I guess maybe one scenario that kind of comes to mind was actually when I was in undergrad. I was going through my biology courses, and I was also part of the tennis team there. And there was one teammate that was really struggling to try and make the roster. They were trying to practice and improve their shots, their serves, and their forehands and all that. And me being on the lineup and one of the captains of the team, I thought that I appreciated that they were working that hard.
Were you the captain or one of the captains?
There's two captains on the team, so a co-captain.
I thought you were being humble or something.
No, yeah, two captains. Okay. Two captains. Yeah, last name is Humblet, so I guess that's
that's right.
Anyway, so two captains. I was one of them. This guy was really trying to work hard to try and make the lineup, and asked me, "Hey, do you want to stay back? Can we do some drills? Can I work, my forehand with you?" And at that time, I was really busy. I had some lab reports to finish. I had some priorities from an academic point of view, but those weren't due just yet. I still had time to stick around. So I spent an hour with him. We developed, some technique changes for him to improve as a tennis player. And then, I went back to try and get my studies done. It was a long night. It was only an hour, but then it kind of disrupts your rhythm. But that's a scenario that I can kind of think of off the top of my head.
Good. And remember, I think the toughest thing about that question is the fact that, there's lots of little things that we will do continuously for people throughout our lives. And it's hard to think of some kind of big, massive one. So I think the fact that you thought of that, I think that's a really reasonable answer. Like, often people are in the situation of donating kidneys or giving up their career for someone. So just to know that you came up with a really reasonable thing where you gave your time for someone, and it just meant that you have to work later, but you saw the value in this, helping your mate, trying to getting them into the tennis team or doing a bit better. I think that was a really good example and just genuine. So that was great. Hey, what are you, outside of your CV, what are you most proud of?
Well, for me, the main thing right away is my family. So I have a 10-month-old daughter, and she is, just the love of my life. She's awesome. My partner has been around with me for, I don't know how many years now. Don't tell her that. I would say like 6, 7 years, 8 years, and she's been there supporting me. So that my family, I love them, and I want to do the best for them, and they've been backing me for forever. So that's what I'm most proud of.
That's great. That's a really great thing to be able to say. It's definitely not on your CV, and the fact that you've got a 10-month-old. I mean, already as let's say my interview, I'm like, the heartstrings and the cuteness of a 10-month-old. Just again, the emotional connection to that person.
Maybe I'll bring her out during the interview.
yeah, that's right. Just by the way, it's something I prepared earlier. As long as it's not crying or
exactly.
needing a nappy change, you're all good. Look, that's, and again, I think there's the constant thing is that you definitely. So that's a great scenario. I'm just going to say it a little bit differently. Just see what you think. So that's a really easy question for me. My family is the thing I'm most proud of. I've got a 10-month-old baby girl now, and she's the absolute love of my life. And when I think of what my family has done for me, and just the connection we have together. My wife, she's supported me for the last 7 years. We've been together, traveled cross continents through med school, through things, and the love I have for my family and everything that we're developing together and the life we're building is just beyond anything. Something like that. To specify those key points, I don't know. That's awesome. That might be a terrible answer for you, so don't take that.
No, but that's amazing, and that's the difficulty in answering these questions is coming up with something that sounds so eloquent. I'm just naturally, I'm not the best speaker. I can speak. I like speaking with people, but just when it comes up in terms of, how to phrase certain things to make them sound a lot better. Yes. That's where I struggle,
So, and I think this is not a bad thing. Okay. So you've got, let's say you've got the most natural speakers in the world. I've only seen a couple in all my kind of history, like maybe once every couple of years on interviewing, you'll see just the most natural speaker who doesn't sound rehearsed, who gives excellent content. The next person is the extremely rehearsed person, and they're okay. I expect them to be rehearsed. I expect them to have made an effort. And as long as the data points they're giving is good to me, I don't penalize them for their naturality. The fact that they've done a bit of work and they're not natural, that's great. I care, like the interview has no evidence for success in your specialist career, but the fact that you've turned up, and it's part of the process, you've turned up, you've made an effort, shows that you know this game and you're going to play whatever game the training program throws at you. So that's what that tells me. This is not everyone's opinion. It's just, this is my opinion. And then the next level is relaxed speaker, a little bit less rehearsed. So you're falling between the rehearsed and the relaxed, and that's not a bad place to be. Like I want you a little bit more in the kind of the formal-ish setting, because you want to be able to just say the words out with the data points, and that makes you a little bit rehearsed, but that's fine. Your manner is absolutely right for this. You're likable, you're telling genuine stories, you got real facts, you got a real interesting life already. So yeah, I think all of that's going really well. Let's go with, how about this situation? So you get your anesthetic training job, and in your first week of that job, as you walk into the anesthetic, let's say the anesthetic room, it's your consultant is there, there's no patient there, and you notice that they're injecting fentanyl. They don't see you, and they walk out of the room as you walk in, but you've definitely seen that they're injecting fentanyl. What do you do?
Okay, so that's a difficult scenario, obviously for multiple reasons. The consultant's injecting fentanyl, so that's for obvious reasons, that's a bad point. Second issue there is really me as a first week registrar trying to approach a consultant, and with this problem is another difficult point. So the way I would approach this is initially making sure that the patient is safe. If we're in there and we're preparing a case, and I've seen that the consultant has definitely injected fentanyl, this is something that I have to escalate right away. This is not a scenario where I try to seek some more information or anything like that. I've definitely seen this. I need to go see either the duty anesthetist or the supervisor of training or a senior right away. Once that's complete, I think I'd be comfortable enough to approach the consultant and tell them what I've seen. But again, it would depend on the scenario. If it is something I'm not comfortable doing, and alerting them, I would just go, as I said, right away to the directors and go from there.
But let's say at that point, so you've sorted out patient safety, you made sure that now you're looking after the welfare of your colleague, and you rightfully escalate it, and you're all in this meeting together, and they approach the consultant, and consultant goes, "Yeah, look, you got me. I've got a drug addiction problem. It's horrible. I'm going to get help." And then they say, "Look, I'm going to go home. I'll talk to my wife. We're going to see a psychiatrist, get drug and alcohol involved," and then heads for the door. What do you do?
A few issues there. So we know that drug use and suicide rates, and also being confronted about this in the workplace is related to, are all interconnected. So I don't think I would feel safe letting that consultant go for multiple reasons. For that one, also, they're under the influence of an opioid, fentanyl, a drug. So I would try to, corral the rest of the team and mention my point of view and why I'm worried, and try to keep an eye on them and not let them leave on their own. Hopefully, get admitted if that's something that is required.
Good. Hey, so that's a great answer. So first of all, you summarize the awkwardness. This is a really tricky situation, not because of not just the fentanyl use, but the fact that there's such a hierarchical problem here, and potentially, it's anesthesia, like things go wrong very quickly and the patients could be at risk as well. So you gave me that summary. You talked about patient safety, pretty much talked about the welfare of your colleague as well. So patient safety, colleague welfare, important. Often the room and other staff welfare could be another thing in other kind of professional kind of scenarios. I like that you said, look, there's no real info to seek here. You've witnessed it, so you addressed that and you moved on, which is fantastic technique for when there's a structured way of saying something and this deviates from the structure. To acknowledge the deviation is really useful like that. And then you gave something that's realistic. Realistically, am I going to talk to this consultant? It's such a hierarchical distance that you'd have to just go straight to your supervisor of training or the director and or the head nurse and talk about this. And that's the end of that scenario. And just to push you a little bit further, there's an ANSCA document on this kind of stuff from the welfare documents on the ANSCA website. And really goes through the fact that the high suicidality and you can't let them leave. They need to be admitted. It's way above your pay grade. Calling security if need be is kind of what I recommend. So that was a great answer. Let's go. Last scenario. Let's go to a clinical scenario. It's actually the one we gave to the critical care interviews this year. So
okay,
let me try to remember it. So you're in theatre with your consultant. And so they're busy, obviously, doing a case. And then you get a call to review the next patient. The next patient is a 70-year-old fractured femur, fractured off. And they've got a whole bunch of past histories. Let's say there's a type 2 diabetic on insulin and oral hypoglycemics, ischemic heart disease with a stent 5 years ago. And I think I mentioned they're 70 years old. They've got Parkinson's and hypertension and hypercholesterolemia. The nurse who asked you to come and review them immediately says that they're also now disoriented and confused. How do you approach the situation?
Okay. So main issues in this clinical scenario, I think, are multiple. So the consultant is busy doing a case. I think in a normal scenario, I would want the consultant to see this patient. It's a patient that's comorbid, newly confused, but they're busy at the moment. Next issue is, I guess, the suitability for us to continue and proceeding with this case in the context of new confusion. So what I would do, I think I would initially go see the patient. I would notify the consultant, hey, there's some concerns of our next patient. They're nearly confused. Let me go take a history and examination, and I'll report back to you. So that's my initial steps. I would go review the patient, review the chart, see if this confusion is new, if they have a past medical history, or they do have a past medical history of Parkinson's, but I'd like to try and get some collateral to see if they're more delirious or anything like that. And also,
so it's acute, definitely recent in the last hour or so. Keep going. How do you sort this out?
Okay, so if it's acute new confusion, I'm trying to think of my differentials here. Number one would potentially be that the patient is in pain. They have a neck of femur fracture. So that's one thing I want to make sure that they're adequately analgesied and their pain is under control. They're also type 2 diabetic, so I'd like to do just bedside BSLs to make sure that there's no issues from that point of view. And they're a 70-year-old gentleman. I'm not quite sure how long they've been on the ward or if they've been on the ward.
Let's say they've their operation has been delayed for 3 days due to inadequate theatre time. So they've kind of been in the hospital for 3 to 4 days.
Okay, so over there could be some main issues. I'd like to see if they're on VT prophylaxis to see if there's potentially, a clot. Other issues there, the patient could be constipated. If he's in pain, he might be receiving opioids or other pain relief that could cause constipation and then lead to confusion. The patient could also have another brewing infection acutely in the context of their type 2 diabetes and high cholesterol. So, yeah.
And as you're going through this, obviously and again, I've thrown this question out because it's a question that's not anesthetically specific, but very relevant to it. And any junior doctor will have managed this, hopefully. So that's part of the thing. Now, as you went through your differentials, you probably noticed oh my God, there's a lot of differentials here. So how would you systematically, or how would you group them? How would you categorize them so you didn't miss anything?
Yeah, I guess there's a few different ways. The way I approached it was most likely to less likely, but there's also another framework, in med school. I don't use this one that much, but Vindicate. So thinking of the different
what is Vindicate?
Anatomy. So vindicate, initially you have your vascular causes, I is your infective causes, N is neoplastic, which is probably not the case here. D, drugs, if there's any drugs that they're using. I is immunological, if I remember well, or I iatrogenic, yeah.
Yep.
Vindicate.
C,
C,
right?
C, I think congenital, not relevant here. A, can't remember what A is.
Autoimmune, maybe?
Yeah, autoimmune. T, I'd have to.
That's right. T is probably trauma, and E is probably endocrine. I've got.
Yeah.
This is good, right? So everyone should have a system. If they get a question, they're like, causes of something, and I don't have a specific system. Like you'd never use this for stuff that you just knew really well. Like say, hypertension is preload, rate, rhythm, contractility, afterload. This CANED is what I use. So CANEDIT, congenital, autoimmune, neoplastic, endocrine, drug, infectious, and trauma. I can be immunological as well. So when I think of this, you can absolutely use that. So first of all, just to give you feedback on that, absolutely. You attended and you highlighted the problem here of a recently deteriorated patient. They're sick and they need surgery. You go up to attend. Now, the first thing you do, because you mentioned history examination, but because this is a sick patient, one that's newly deteriorated, you have to say A to E assessment. And at that point, you may briefly go through it as quick as you can, and I'll then offer you some investigations, and they'll be like slightly tachypneic and slightly tachycardic and hypertensive. And I'll give you a BSL as well, and a temperature, which is kind of normal. At that point, then what you're saying was all reasonable. I like the fact that you mentioned specific things. And I really do like what is most likely, what is most serious, and then a categorized list. So what is most likely, look, this could be due to pain. It's an elderly patient. Maybe they're off their Parkinson's meds, and maybe it's just a delirium due to being in a hospital that has no other cause, that's hard to ascertain. But the serious things I really want to rule out are a cardiac event, PE, hypoglycemia, infection, sepsis. And then all of my differentials will be based on physiological. So I'll make sure all my parameters are normal. I'll take a VBG and check those parameters, sodium and glucose, as I mentioned. So your physiological, pharmacological, I'll look at the drug chart, see what they've given, too much opioids, benzos, antipsychotic medications, any neurologically active stuff, serotonergically active stuff, I would also look for. And that's your pharm, and then neuro and other meaning your cardiac or system by system. So this is a huge differential type list.
Yeah.
Just to clarify for everyone, I went through A to E. That gives me a lot of good stuff. Then I went through phys, pharm, neuro, and other. Other can be lots of things, but it could be system by system, just to make sure you haven't missed anything. I also overlaid that previously with what's most likely and what's most serious. And this is a common structure I use for diagnosis and intraoperative problem solving as well. What's most likely, what's most serious, and then a categorized list of differentials. It doesn't matter that you don't get everyone, right? Because there's so many, but you show that you've got a really good process. And literally every time I ask a clinical scenario, this is kind of the framework. Attend, highlight the problems. If there's anything particular, show that summary statement shows you got an overall idea of what's going on, A to E assessment. And then this is my most likely, most serious, and categorized. And this is how I figure out this is how I diagnose each of those things quickly and briefly.
Yeah. No, that's great. A lot more thorough. Yeah, no, that's good.
All good. Hey, so Alan, that's probably enough time of grilling you. Did you have any questions at all?
No, that was great. And I think any practice that you can speak out loud is great. So I really appreciate you spending the time there with that. Once again, it's just trying to figure out how much time and how much detail in those motivational ones, because I have things I want to mention, but I feel like I can't hit them quick enough, or they sound too waffled. So it's just something to keep on refining, I guess.
If you time yourself and say everything you want to say, but just the highlights, I suspect that you will still be 2 minutes. It's not a problem.
Yeah,
you're speaking fast enough that you'll get things out. So I don't think I'd worry about that. I'd just, as long as you're not speaking extremely slow, which you're not, you will get everything you need. So almost for you, I wouldn't worry about that. Just get out the highlights. As a take home, often when I do this kind of, practice and coaching, there's always something about the person, and that's going to be the key feature of where they're going to have a hang up. And if there's anything you worked on, it's not bragging. Just say the fact. If it's a fact, it's not bragging, and you're proud of it. That structure that you use. I'm really proud of this. Say it with genuineness, and you're not trying to show off something. They've asked the question. I would just get really used to saying that. Get really used to saying each of the best parts of your CV, which is the fact that you're on a NCAA athletic scholarship, amazing. International tennis coach, amazing. Founder of a society, amazing. Reviewer for a journal, amazing. You're doing an RCT, doing lots of elements in it, amazing. And then you've got some great stories there that you can imply. So practice saying those things and giving a little bit of detail for each, a teaser, a little bit of detail, and practice in front of your 10-month-old, in front of your partner, in front of your family, in front of your best mate, because they'll grill you and laugh at you. And if you can do that, you can probably be okay with an interview panel.
Yeah. Cool. Awesome.
All good, Alan. So, really good luck for the next week. Definitely let me know how you go, and wish you all the best. And thanks very much.
All right. Well, thank you so much. I'll keep you posted for sure.
Beautiful. So that's the end of this episode, everyone. So please share with anyone who might be interested, and we'll see you again next time. Now, what's new with ABCs of Anaesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.